Once again, I am Constantine. I'm one of the second-year fellows. Dr. Cook, say hello.
Hello, it's Jen Cook. We're doing part 2 of our mechanical circulatory support talk on the Impella.
All right. So what we're going to talk about here is we kind of start off balloon pumps. Like in many ways, the Impella offers more support than the balloon pump. And we'll kind of talk about indications, contraindications, placement, complications, all the good stuff that you need to know to kind of succeed in the CVICU. And these are, once again, really pretty cool tools that we have to help support our patients through some rough times. So I think it's very important to kind of reinforce the fact that all of these devices don't replace the work of the heart. They kind of help support the heart. So the classic example that I use is basically this gentleman right here. He should have a spotter. With the use of a spotter, you still have to do your own work, but the spotter may offload some of that work to make it feasible to push some of these weights. What we're really trying to do is avoid a situation like this, where typically this looks like hypotension and pulmonary edema, all those kind of nasty things you see with heart failure. We're going to use a spotter in this situation. I can probably get him into a better spot where he gets stronger and avoids, neck surgery or whatever this may cause. So anyways, let's get to it. So on I guess my left here, you can kind of see an Impella device placed. And this is kind of, in a perfect world, what they look like. They have some, pretty specific indications. In terms of plans, you kind of hear about high-risk PCIs that will often be used for somebody, let's say, with a high-risk lesion, let's say a proximal AD or a left main lesion and a low EF, where whenever you do work on them, there's some expectation of hemodynamic shifts and things of that nature. This is just a way to kind of get people through that. And VT ablations, we're causing a lot of ectopy. And if somebody has a low ejection fraction, we may elect to burn an Impella to kind of support them through that. And then lastly, cardiogenic shock, which is going to be a lot of the focus of your patients in the CVICU. This is basically what an Impella looks like. It's a 9 French catheter. So that's about the size, I think slightly bigger than the basic, the HD catheters that we use in the ICUs. It is an angle pigtail, has about a 45-degree angle. And essentially what it does is this little thing sucks in blood, and it kind of gets released at this area right here, going from the LV out into the aorta. And there's different types of support devices where, as you have these different numbers, we'll talk about these a little bit more specifically later, the size of the actual cannula changes. So here you have a 12 French, 14 French, and 21 French. Just as a reminder, as French goes up, the size goes up. It's not like gauge, whereas as the gauge goes up, the size goes down. French is true to size. So as that goes up, the bigger the insertion is as well. And what's pictured here is a 2.5, and it kind of shows you the general shape. So it's important to know that these are axial pump flow devices, where essentially there's a rotor here that spins around, and as that spins around, it creates a suction, and it basically sucks out the blood. And you can imagine if any sort of rotor or anything that kind of spins around in your bloodstream, there's going to be some degree of hemolysis that happens, and that's something that we definitely look for in our patients. But essentially, this is just a motor that kind of spins around and creates that suction effect and gets the blood from point A, which is roughly here, to point B, which is out here, to kind of help offload that work of the heart. Most of your Impella patients don't look discontent, and their nurses tend to not look discontent. They tend to be fairly sick. There are folks that once they kind of get them out of the acute stage, they do start to look a little bit more like this. I think that's always really rewarding. But at the very beginning, when they go in, rarely do people look like this. This is a man who's probably on his way down to get his Impella removed that day, if I had to guess. Essentially, once again, femoral access is what you'll see most often. Not to say that we can't use other access sites, but this is the one that you'll see most in the ICU. And just like the balloon pumps, these have to connect to something. So there is an external console that it connects to, and the Impella is positioned inside of the left ventricle. Juxtapose that to the intra-aortic balloon pump, which fully rests in the aorta and does not find its way into the heart. One of the other access points that we can use, typically in instances of severe peripheral artery disease, is the axillary approach. but they're kind of a pain in that, unlike femoral, you can just kind of access under ultrasound guidance. You actually have to have a vascular surgeon do a cut down, expose the artery, then we cannulate the artery, and then later, when it's taken out, vascular surgery once again has to be involved to close the arteriotomy as well as the puncture site. So it's a little bit more involved, but if that is the only access point we can use, you will go ahead and use it. For some of our bigger Impellas as well, this is the only way to use them. We can't use a femoral approach.
Yeah, at UC, we'll see the CT surgeon sometimes doing the cannulation, the axillary cannulation, but vascular surgery is almost always involved in the decannulation or the explant of the device. And just like you said, the Impella 5.5 is the largest pump that we have and is probably the best pump in some of our larger patients. It only can be implanted with a cut down, whether it's a femoral cut down with a graft or an axillary cut down with a graft. But the CP, which is a 3.5 device, can be placed percutaneously in the leg.
Thank you. So if you go for the big gun, there's surgeons involved, and that's always helpful. But with every procedure that we add to the patient, as the size goes up, obviously the risk of complications unfortunately also goes up.
I don't know if you've had a chance to be in any of these decision making at the bedside for these patients that go on mechanical circulatory support, but as you can see from our balloon pump talk and from this talk, the advanced heart failure team is multidisciplinary, which includes interventional cardiology and CT surgery. So typically the decisions about what support somebody goes on is made by the three of those attendings together. And sometimes our fellows are the ones that are in the middle of the night trying to get us all, updated on the same page. But typically, as you can see, CT surgery is assisting with the Impellas, and then of course it's cannulating for ECMO. And so many of the times we're making these decisions as a team.
And those conversations are really pretty interesting because whenever you put these support devices on, you have to kind of have an exit strategy right away. Kind of think about, right, well, if this fails, what are they a candidate for? Can they go on ECMO? And you always have to think maybe 2 or 3 steps down the line, not just in the present moment. And those conversations actually happen at the time of decision when we say, all right, if they go on Impella, are they ECMO candidates? Is this a bridge to something, to recovery, to transplant, or sometimes if it's a bridge to nothing, then maybe this is not something we should do. It's really kind of interesting to be a part of those conversations. I think as the residents, I encourage you to kind of at least listen in and kind of think about the thought process that goes into making these kind of big decisions for critically ill patients, because that's I think one of the real benefits of rotating with us in the CVICU, where I think a lot of those conversations don't happen in other units. And it's really neat to kind of watch very smart people have very high-end conversations. And at a certain point, I am starting to catch up, but fellowship is a 3-year process for a reason. So we're getting there. So one of the things that you may see the fellows do, or this is something that really a lot of folks will do, is if you start to have alarms or any sort of concern about malposition of the Impella, or even sometimes you're just curious to make sure that's in the right spot, we'll actually grab an ultrasound probe and do a kind of a limited echo, particularly this peristernal long view, where in the ideal figure it kind of looks like this. But in a real ultrasound, you can kind of see more of this, where you can see this is the aorta, this is the left ventricle, left atrium, right ventricle here, and the device is entering the left ventricular cavity right there. So we'll do this sometimes to kind of adjust Impellas to make sure they're not too deep or not too shallow, and we may adjust these on the go because they, as our patients sometimes get agitated or get moved, they can shift as well, and you don't want these to be in the wrong place. As we kind of mentioned earlier, there's kind of a handful of Impellas to choose from. They're kind of numbered by the amount of support they have. One of the really important points that you want to bring up is that the Impella does not add to the support that your heart puts out. So, for instance, an Impella 2.5 will pump out 2.5 liters per minute. That is not on top of your cardiac output. That is just what it pumps out. As opposed to the balloon pump that we mentioned earlier, actually adds to the cardiac output that your heart puts out. So, if your heart is putting out 2 liters per minute, which is abysmal, by the way. It'll go up to 2.5, which is also abysmal. If your heart is putting out, 2, when you put an Impella 2.5, and it's still going to go 2.5 just because it's what the Impella is. The goal is to kind of get your heart into a better place. We can use medical therapy to kind of heal the heart and eventually, hopefully, not need the support of the Impella. But this does not, it is cardiac output that is not in addition. It's more just in support of what your heart is already doing. Going from right to left are kind of increasing sizes and increasing amounts of support, going from a 2.5 here to a 3.5 to a 5 to a 5.5. I don't think I've ever seen a 5.5. Maybe I have, maybe once or twice. But we tend to have abandoned the 2.5s because they don't offer too much support, but we still see them used in rare occasions. But the point of the slide is just, what the type of Impella they have is important because there's different, sizes of access and kind of the pump sizes are different. And it's helpful to know which access do they have, is it appropriate, and what do we have to do to get it out. So for instance, with this 5.5, it's good to know that it's a, direct surgical insertion because hopefully if it comes out, we know to call all the right people to help us out. On the actual console, these are some things that you can see. You can see the aortic pressure. You can see the LV pressure. And this is kind of the motor current telling you, how the motor is working, if it's revving up or struggling and coming down. And there's sensors at different parts of the Impella that kind of get these measurements. And these are helpful just to know that there's no clots and, there's things are kind of working appropriately and placed appropriately. This also will spit out a cardiac output for you, which is somewhat helpful, but many of these patients do get a Swan-Ganz catheter, and we do follow those as we try to medically optimize them with the help of these support devices. So this is just a close-up, and this is kind of hot off the press. I had the fine folks of Impella send me their most recent devices, so this is kind of what it looks like. And it's good to know what these are like at the bedside. The other thing that's important to know is it kind of shows your purge flow. That's a heparinized solution that goes through the actual Impella to make sure that it doesn't clot. And we'll talk a little bit more about the anticoagulation needs of these patients and these machines in a little bit.
This is an example of the Smart Assist monitor and module. And the Smart Assist is actually an upgrade from what our old pumps used to show. And so what we're seeing on the top, which is the yellow box, is the red aortic waveform, and then the white left ventricular waveform. And so you can imagine if the Impella gets pulled out to where it's all in the aorta, then you'll lose the LV and diastolic pressure that you see there. Or if it's too far deep, you'll lose the elevated diastolic pressure that you typically see in the aorta. And so this is really what's helping us determine the position of the Impella, because it's giving us the pressure in the aorta and the pressure in the left ventricle. And so this is the Smart Assist software, and our Impella 5.5s and our Impella CPs that we're using now both have this.
And the other thing that I'd like to mention is this P9 right here in the right corner, on the right side. Is kind of, how fast is the motor going, kind of. So how much support are we providing from this Impella? So as we try to wean down, you'll see us go from P9 to P7, P6, P5. We kind of work our way down in some real, somewhat slow fashion to see what can our patients handle by themselves and how much assistance do they need from the device, and how quickly can we get the device out. So the P settings is what we work on to try to figure out, when can we wean the device.
The P is the power level or the speed. P9 is the highest, and P2 is considered to be neutral.
Mm-hmm. So never a P0. So for contraindications, this is really important to know because we get patients that are really sick and we have to do something quickly, but it's really good to kind of quickly go through these in your head to make sure that once again we're delivering as much help as we can without offering harm. So if you have a mural thrombus in your left ventricle, really any sort of thrombus in your left ventricle as a contraindication because of the high risk of stroke. So in the last balloon pump series that I kind of mentioned, my patient who got the balloon pump and really improved, he's somebody that, if I could have him my way that night, we would have had an Impella place, that needed a bit of support. His turnaround of the balloon pump was really pretty impressive and unexpected. But unfortunately, he had an LV thrombus, so he wasn't a candidate for an Impella, and we had to go with the balloon pump, which fortunately worked for him. But in other patients, I'm not sure if that would have held true. But if you have an LV thrombus in the left ventricle, you can't put an object in there because it can dislodge it and lead to stroke. If you have a mechanical aortic valve or any sort of heart constriction device, that's going to be a contraindication. Any sort of aortic valve stenosis / calcification. And it really talks about, an orifice of 0.6. So that's really critical aortic stenosis. You're not going to be able to get a device in safely. And it would basically, if you have a really tiny hole and you occlude it, that's a real problem. So that would be a contraindication. If you have moderate to severe aortic insufficiency, and the problem that happens there is if this is your aortic valve and things are supposed to go this way, but things keep going this way, whatever you pump from the point A to point B is just going to go right back. So you kind of create this cycle that's really ineffective to helping perfusion or augment any of the LV flow. So, moderate to severe insufficiency, you're not getting the benefit of the Impella. Similar to the balloon pump, if you have severe peripheral artery disease, you can't, really put on an Impella safely because you can lead to the same complications of thrombotic strokes and kind of, vascular disruption there. If you have right heart failure, this is something that's a little bit more unique to the Impella than the balloon pump, where, if you're helping the left side of the heart, the right side of the heart will have to work too. And, you're not doing that. So if you have RV failure, putting in an LV support device may worsen that RV failure and may not help the patient. So you kind of have to, take a look at the patient and figure out, can their RV handle the increased workload that we're about to give it? And if it can't, then maybe the Impella is not a good option for that patient. And this is something that, comes up time and time again, because we kind of get patients that, the most common cause of right-sided failure is left-sided failure. And folks are decompensated for a while, coming to biventricular failure, and they're pretty tough to treat because you're worried about kind of flooding that RV and precipitating right heart failure, which is really difficult to deal with.
I'd like to add one other physiologic pearl there is that, remember, with a continuous flow pump in the left ventricle, you need to have adequate preload in the left ventricle in order for the pump to work. And so in situations where you have right ventricular failure, we're dependent on the RV to actually pump blood through the lungs and to supply preload to the left ventricle. And so that can be additionally problematic. Not only can you precipitate worsening RV failure, but suffer from decreased preload to the LV, and then suck down and ventricular tachycardia in the LV.
Right, exactly. So we actually let these people run a little bit more wet than a lot of our heart failure patients, just to make sure that they have the cavity that's a little bit more distended, so the Impella has room to work. Now, as we kind of diurese them over time, we feel like they're close to being off support device. We tend to go back and try to get folks a little more dry, but we're a little bit more lenient to volume status when the Impella is in because of that. VSDs, ASDs, obviously if you have left ventricular rupture, sticking a foreign object in that space is not a good idea. And tamponade is also another contraindication because it's almost like diuresing somebody in tamponade, not a good outcome. Their heart failure will not improve from that. One of the things that we also should talk about is the anticoagulation. As I alluded earlier, the purge solution that comes through these is a heparinized solution where your PTT goal is 50 to 70. And, often the purge solution, which just goes through the Impella, is sufficient, but sometimes it's not. We actually have to put people on systemic anticoagulation through a peripheral IV as well to make sure they are anticoagulated. So unlike a balloon pump, which you can put on one-to-one with really no anticoagulation, all folks with Impellas need to be anticoagulated.
If there's one single thing that you learn from this presentation, the most important thing that you can learn is that there needs to be heparin in the purge solution. Mm-hmm. And I would hope that as soon as a patient is arriving from the cath lab, that's the first thing that's checked, is whether or not there's heparin in the purge. A lot of times the purge will be hung, which is just like D5W without heparin in it. And what happens is that fibrin will deposit in the pump early on, and then you'll have hemolysis throughout the rest of the Impella run. And so it's important that they get heparin early and that they're maintained. And you might ask, why might they not get heparin in the cath lab? Remember, they're getting bolus as part of their intervention and that type of thing. So they're coming to us with ACTs that are similar to their intervention, but as that is as their heparin bolus is wearing off, it's important that they have at least a small amount of heparin in the purge.
Perfect. Yeah, because once you have hemolysis, these aren't devices that we like to exchange. So you really want to make sure that from the beginning you do everything nice and keep everything tidy, because once you have any sort of thrombosis in the pump, you're really asking for big time issues, because once again, it's an arterial side system. So anything that thromboses or dislodges off that thrombus is going to go towards someplace that has a really low ability to tolerate that, such as a brain or a leg. So we want to keep a close eye on these patients' anticoagulation. I always liked figures like this, because I never, I always had a hard time kind of wrapping my mind around how these things work. Physiologically, what is the benefit that I'm getting? And the best way I can really describe it is, at a certain point, your heart becomes so bad where you're so far off the Frank Starling curve, where the typical medications we use are just not enough. It's almost like a forest fire. My super soaker is not sufficient. You need something more. You need mechanical support for that too. So the Impella is a way to basically really functionally suck blood out of the heart and hopefully kind of shrink it to a size that's a little bit friendlier towards your sarcomeres. So basically you can have better contractility and better function. And with your heart kind of shrunk into a better state, you can use medications to kind of optimize all the things, be it preload, afterload, whatever it may be. It buys you time to make those adjustments and make sure that you give the patients a shot for medicines to work. Because if we've gotten all the way over here in the Frank Starling curve and medications aren't working, the only way we can get people back is to have additional health with a support device. And this kind of illustrates that well, as you really stretch out here, pulling back some of that volume by using mechanical devices to kind of, in the case of Impella, taking blood and really just displacing it from the LV into the aorta is enough to help a lot of patients get over the hump and get their medications to start working. So you're really just trying to support their LV. You're not replacing it by any means. You're giving it what it needs to do its job better. Once again, you got to talk about data. So we'll talk a little bit about some of the studies that have been done with Impella. So this is a study that looked at the use of an Impella 2.5. Once again, this is kind of the lower end of support that Impella's offer, and patients are undergoing high-risk PCI. So this is folks go under left main, proximal AD, that had an Impella versus a balloon pump. And essentially, this is either complex three-vessel disease or unprotected left main. There are 452 patients total in the study. They were split evenly between the balloon pump and the Impella 2.5. And what was tracked was really the major adverse events at discharge or 30-day follow-up, and looking at death, STEMI, NSTEMI, stroke, renal failure, hypertension, failed PCI that required repeat revascularization, CPR, VT, or aortic insufficiency. And what they saw was essentially kind of a splitting of graphs at about 25 days or so, a little bit earlier on the right side, where the balloon pump had more major adverse events as compared to the Impella. So between these two devices, it seemed like there was a statistically significant and really clinically significant difference between the two support devices when used for planned complex PCI. So a lot of our interventionalists, before they do complex PCIs, will prefer Impellas over balloon pumps, but sometimes a balloon pump will get them through as well. The other thing we looked at was looking at circulatory shock and cardiogenic shock after an acute MI, where we used either an Impella versus a balloon pump. This study was a little bit less friendly towards Impellas, where basically the mortality like we mentioned earlier, stuck around 50%. So these are very sick patients. And between the Impella and the balloon pump, there was really no difference that was found there between the two devices. That's an Impella CP, which, provides quite a bit of support, and, the balloon pump. So there's, 3 major randomized controlled trials. Unfortunately, none of them show a true mortality benefit, which is really, surprising. A lot of them are, the issue is low power. You can't really recruit that many sick patients and kind of randomize them. The biggest trial, Impress, was only 48 patients, if that, shows you anything. And there's actually a national cardiogenic shock initiative right now where they're trying to get a database of a lot of these patients, trying to, figure out more of an objective truth of, do these support devices help, and what is the long-term outlook for people that get support on these devices? I think overall they're pretty sick patients. We keep kind of coming back to this 50% mortality rate. We're still trying to kind of tease out what advantage, if any, the Impella gives us or the balloon pump give us. Anything you'd like to add, Dr. Cook, to any of this?
Yeah, I think just to summarize it, there are 3 main indications for Impella. One is protected PCI in the setting of left main or triple vessel disease, or protection during a VT ablation. The second, I would say, is STEMI shock. So a patient presents with a ST elevation MI or a non-ST elevation MI that has cardiogenic shock. And that would be more of the shock 2 cohort. And then the third are patients that have that have end-stage heart failure that progress and present in cardiogenic shock. And so the 3 different groups are a little bit different. The least amount of evidence is in the patients that we probably use this the most in, which is the chronic heart failure patients that present with acute cardiogenic shock. But just to emphasize, as you laid out so nicely, is that, device selection is important. And then when we're considering device selection, we're considering what the bridge is to, and whether the patient has a chance of recovery like they do with the STEMI shock that have had revascularization, or perhaps somebody who has end-stage heart failure is going to need to be a bridge to advanced therapies like a VAD or a heart transplant.
Yeah. So, the evidence for these is not as robust as I think any of us would like. But, when you're kind of faced with these critically ill patients where, you're giving maximal therapy and that lactate keeps rising or their kidney function keeps going the wrong way, we try to use something. And I think sometimes it works out, and unfortunately sometimes it doesn't. And the ones that work out, you really remember. And unfortunately, the people where it doesn't work out, they tend to be very sick folks with a high mortality just coming into the hospital. So we do the best we can, and we're trying to offer as many things as we can. And these are all things that we need to really study further. But these are really good devices to get exposure to. And like I said, they're pretty unique to our ICUs. And the more you can learn from them, and the more you can kind of learn to manipulate the Swan-Ganz numbers with these in, the better your understanding of physiology and the better your understanding of what we're trying to offer for a lot of these advanced heart failure patients. So this is basically our review. We really look forward to working with you guys and learning with you and learning from you, because I think it's so helpful to have residents on our teams and kind of offer really insight about stuff we sometimes don't think about. We kind of get caught up in our own practice patterns. It's really refreshing to hear something new every now and again. So we appreciate all of you guys, and hopefully you guys will have a wonderful experience with us as we have with all of you.
Yeah, thank you so much.